Okay.
Yeah.
Assalamu alaikum everyone. My name is Zahid Sayed. I'm a sophomore at Georgetown University in DC. I'm from New Jersey. And there are a lot of doctors in the area, and they offer, a lot of them offer like free patients in the masjid. They see them. So me and my father, we wanted to try to create a more organized effort. I looked at like the Ummah Clinic in California, and I actually went to your website, MCC. So we're trying to create something in New Jersey.
I'll fill in. So, Sajid Sayed, not a physician, but I serve on, work with a lot of physicians, and I want to start this. I've been meaning to start this for a long time, but I serve on, work with a lot of physicians, and I want to start this. I've been meaning to start this for a long time. I think there's a need, and as my son said, in my neighborhood, there's probably around 300 to 500 Muslim physicians who want to help and support this, right? I do serve on a large mainstream not-for-profit clinic. It's called Greater Philadelphia Health Action. I'm on the board of that clinic, so we probably serve close to 80,000 patients over there.
So what's the name?
GPHA, Greater Philadelphia Health Action. And the reason I joined the board is because I want to learn the business model. My background is in managed care. My primary clients are all managed care insurance companies, especially managed Medicaid insurance companies. So like in Baltimore, I work closely with Hopkins. They're a client of mine. Hopkins, it's a large Medicaid population, we should talk offline. So our model has been basically, we bill 60 to 70% of the patients on the Medicaid side, and then the remaining 30-40%. So we try to keep a very good balance between our insured and our indigent population. That's the key. So like you said, for the indigent population, which is primarily the migrant population, we get a lot of Latino migrant population into our clinic. And we have, like I said, 13 clinic sites. So we also have our FQHC deemed status, which means federally qualified health clinic. So we get grants from the feds in the clinic, right? When we got the FQHC status, that allows us some grants. We also have our own lab. We basically subbed out the labs to the two big carriers. So we only pay $2 for a lab test, compared to what a commercial patient would pay. The other thing is obviously to put in a dental program. That's a major revenue source for us, the dental program, and we put in a pharmacy program. The pharmacy program has been the biggest blessing for us because the pharmacy alone, we can buy drugs. We put 2 pharmacies in 2 of our clinic sites, and just to give an example, last year we closed almost $1.8 million net profit from the pharmacy, which was able to be used to pay some of our salaries for the doctors. We have around 38 physician providers, and so that 1.8 million pharmacy basically helped us offset some of their costs. The dental, again, probably around $800,000 net, helps some offset some of our costs. So that's what I'm doing today. Obviously I'm just on the board. I don't do this for a living. My goal is to start, and we just incorporating a clinic called the Medina Clinic in New Jersey. I also work on the board of a small group called the Trenton Area Soup Kitchen. So we're trying to learn different models and see how it works. One question I had for the group was, right now we want to do this in 2 phases. So the first phase I'm thinking is, will a coupon theory work? What if, like, you said you're a subspecialist. I have a lot of friends who are subspecialists. Maybe not GI, because GI is you need a lot of tools for that, a lot of toys for that. But somebody who doesn't like a rheumatologist, everybody's got bad knees. Can I give coupons out to patients in the soup kitchen and say, what, here's 5 coupons for, Dr. X, and will that work?
Basically vouchers.
Yeah, like a voucher system.
I mean, why not? But
Why
then,
not?
Do they go straight to a subspecialist? They may be better
That's
served by
true.
a primary care doctor.
The primary care, my issue is the primary care guys view this as competition, especially in light of ACA coming down the pike next month. So once the exchanges go live, right? Exchanges go live in a month and a half, right? So everybody's going to get insurance. So now the hospital is saying, hey, you're going to compete with me now, right? Because the hospital has their own clinic. So that's the thing I'm not sure 100%. The other thing I'm doing is I'm working with the managed care. So I met with the CEO of one of the biggest plans over there. I know him. He's actually a Muslim guy in New Jersey. He's MediHealth. So he's going to send us some. He said, look, I'll give you a guaranteed payment, because at my current clinic right now, we get a guaranteed payment of $164 per visit.
I think that's what we are. I think 2 or 3 things I wanted to say to your. You have been a success story on the pharmacy. we have been totally under the failure. Because, we were told by the Montgomery County that for the pharmacy to be successful, you need to have a full-time pharmacist on. Let me just finish
Sure.
so that,
Yeah.
and you can just tell me if I'm wrong. That and there was really not. We could not find any pharmacist, or we could not even find pharmacy student or pharmacy, intern to look at because they really want to make sure. So ultimately, at this time, we stopped the pharmacy altogether. We are giving the prescription which they can go to Joint or the other places
Right.
on for $4 or something like that.
We can talk
So-
offline. I don't want to hold a group on that, but basically for the pharmacy, you need something known as a 340B status. If you have a 340, that's what we have. We have a 340B status in the pharmacy. If you have that status, you can buy the drug at 50% of market, right? So that's how it becomes a revenue center.
Is that federally or is that different states?
No, it's
Things
a
are very
federal
different
program.
in
It's a federal program.
federal.
It's a federal program. It's called the Office of Pharmacy Affairs that has. It's a long, lengthy process. It takes a couple of years. So like once you apply, it takes a couple of years. If you Google it, 340B, it'll pop up. But again, I don't want to digress and hug up. But
Only
that's
federally funded clinics, not otherwise.
no. You can also be an FQHC lookalike. You don't really need to be an FQHC. You can have all the characters of an FQHC and apply for a FQHC lookalike status. That will also give you a 340B status.
What is that called? HCL?
It's a federally qualified health clinic. Yeah. But that's a whole different animal. We don't want to do that. We don't want to do that. Right now we're thinking, just to create a small clinic, maybe apply for some kind of a lookalike status and then go for the 340B status. It's a process. But right now to start with, I was thinking maybe just a voucher system. So you're saying the primary care needs to be seen first.
They're the gatekeepers. I
Right.
think to have a sustainable model, that's
Yeah.
the challenge getting the volunteers.
Yeah.
The patient may have knee pain, but they may have other systemic issues.
Systemic.
Yes, their diabetes may be so
Right.
out of whack, they don't even know if they have diabetes.
Right.
The rheumatologist will say, well, have you had these labs? No, okay. The primary care it's again a process.
Right.
See the primary care doctor, if it's beyond his or her comfort zone, they go to the specialist.
Right.
On the other hand, rheumatology and diabetology or something, the primary care can take care of that pretty
Easily.
if he's really into his system. On the other hand, subspecialist you need is for cardiology,
I know.
for gastroenterology,
Right.
where you cannot provide the services right there. We have also, I forgot to mention, ophthalmology. I'm sorry, not ophthalmology, but optician.
Optometry and then
Yeah.
ophthalmology referrals.
Yes, that's right. We have a very good person who does that, and then if she finds some issue, then she sends it to the ophthalmologist. Probably you get it also.
Yeah, I get it.
Yeah.
Dr. Fadel,
No, actually, we don't have a clinic. I'm here to listen to see. We want to start a clinic in Augusta, Georgia, where I am, where we have been. But no, I'm just listening to see what different models.
so maybe it's a good time to somebody to give you some ideas so that we can go back to another clinic. If somebody wants to
That's
for
what
a
I'm here
new
for.
for a new
Yeah, cell
clinic.
number.
Anybody has anything like
Is this your cell number?
Yeah.
And
Okay,
mine is, yeah?
Website.
So Assalamu alaikum, my name is Sarah Hesnan. I'm an attorney by day, but I'm volunteering with a healthcare clinic in association with Adams Center in the Northern Virginia area, and I'm actually working with Dr. Samir and Dr. Chaudhry. So we are called the Adams Compassionate Healthcare Network, ACHN by short. Feel free to pick up a business card later on. But essentially, we have been very lucky to get this project off the ground. We're looking at opening in about 4 weeks. Luckily, we have a space that we've gotten through Adams Center. So like MCC, we're not as worried about rental costs right now. In general, some of the things that I'm hoping to learn from this session, I've written down a few questions that I have. We have partnerships with a lab organization that's going to be giving us either free or very, very low cost labs, and we also have a partnership with a pharmacy group that's giving us free or very low cost drugs. We have space, we have equipment, we have doctors. I think what we're personally lacking a little bit in is the governance structure. We really haven't finalized that, so I'm hoping to learn a little bit more about how to properly organize our volunteers, our organization, to have some, day-to-day organization, but also future sustainability and a vision for the future. So basically, what will a governing structure look like for a fledgling clinic like ourselves? And then after that, it seems like MCC had a free or low-cost clinic model and has now transferred over to being more like a private clinic. So what I'm curious to know is why depart from the charity model and move on to a for-profit almost model. So I'm curious, why you all have done that. And then
Because,
also,
let me just answer that. Because our revenue continued to drop. And in the
Okay.
beginning, about 5-6 years ago, about more than 50% of the physicians and the other ones were voluntary. Now we are having very much difficulty finding the voluntary physician.
Okay.
So our revenue is decreasing, but our expenses are increasing. And also because we will be losing our grant from Montgomery County in about 2015. So I think the whole perception is that if we lose that grant, then the revenue will.
I
We
see.
have, mashallah, on our board, we have a complete board not only on physicians, but we have also quite a few financial consultant and economists and all that. And they, in our strategic committee, they have put the whole data like in projection in five years. He said that you will be completely dead if we don't do anything. So the only thing we could suggest, we could come up with that decrease the expenses. We decided that there is really no reason to have the physicians, have the nurse practitioners, and I think the medical director said that, if we just cut 2 physicians, paid physicians, and have 4 nurse practitioners, that will be almost the same way.
Okay.
And so that is the reason we decided to go on the private. And the most fearsome thing we had is whether we will lose our 501c status. And our attorney in the board said, we have attorney also.
Mm-hmm.
We have also patient representative in the governing board who comes and makes sure that the patients are happy.
Right.
They really. So the attorney said, you will not lose that status. So that said, with the Affordable Act coming, losing grants, we decided to go for more. The whole idea is like, supposing if we are seeing 70% of the patient who are Medicaid or insurance thing and all kind of thing, and we are seeing 30% of the patient who are indigent and cannot really pay, then 70%, whatever we earn income from that, will go to provide
They
for those
subsidize,
30% who cannot pay.
Okay.
Assalamualaikum. I'm Umar Chaudhry. I just want to say just a little bit about how we've organized our clinic model. So, I think eventually we'd like to move towards something that you guys have described before. But based on what our plan is right now,
I'm
is that
sorry, what clinic is that?
this is with the Adams Clinic
Oh.
out of Northern Virginia. So basically, the only patients that we're seeing are patients that do not have insurance right now and who have less than 200% of the federal poverty level, because these are the guidelines that we have seen with the surrounding clinics in our area of people who they have accepted. And then as far as all of the services that are provided all on a volunteer basis. So all of the physicians are all volunteer. All of the behind the scenes efforts are all volunteer. And Sarah already mentioned about all the partnerships that we have to have in place for like laboratory work and pharmacies and all that kind of stuff. But right now everything is going to be volunteer and based on private donations. Obviously those don't last forever, so we need to work and figure out how we're going to sustain that either with grants or with charging insurances. I think my main question is there any downside to accepting insurance?
Yes, there is 2 downsides. Number one, you need to have electronic medical record. Some people say it is a downside initially, but my own feeling is I have electronic medical in my own office, as well as we are struggling with. At this time, I can see at the clinic that the patients, like which I used to see, I'm used to seeing a new patient as a gastroenterologist, not as an internist. I take about 20-25 minutes to see a new patient. Now, because of the electronic medical records, I'm seeing one patient almost in 45 minutes. So number of patients are decreasing, and that means the revenue is going to decrease. But that's not a that's temporary. You will get
There's a
back
learning
from
curve.
that.
We have using free.
Yeah, the other
electronic
one is
record.
about the other downside is that you need to provide these services 24 hours.
Yes.
We have the answering service. That doesn't mean that you have to see the patient. All it means is that if somebody calls, says that, I have this pain or I have that, and you think that you cannot really handle it, just send them to the emergency room.
There's a requirement of insurances?
Yes, especially the Medicaid and Medicare.
Also, there is no
And you need to have a coverage, somebody needs to be a doctor there, if the patient wants to talk to a doctor, they need to.
The
So
key, the
the-
mechanism has to be in place.
Can I understand from this discussion so far that it's not a good idea to start a completely free clinic?
So let me just continue because we're in the same process.
Because I have to be leaving.
There's a lot of factors that Maryland and Virginia were right next to each other. I've been involved with MCC Clinic for about 7 years as a volunteer. I used to be there on site.
Yes.
And as a specialist, I get patients. Virginia, North Carolina, and some states have the state being able to back up the liability coverage.
Right.
That's a huge positive. So you don't have to worry about those issues in Virginia, whereas in Maryland you do. And that's why it took a lot longer for MCC to start, because that's extra money, extra risk. But I think one of the big issues that I want to say, we're really not structured. If you look at our name, we're more of a healthcare network. We're trying to get out of the concept of being a freestanding building and call ourselves a clinic. So one of the things we want to do is, just like the brother said, we don't want to be competing with anyone, because then you're going to have ill feelings in the community, whether it's the hospital, the HMOs. We're going to complement what is already, there. So in other words, wherever the gaps in coverage are in the community, that's where we want to come in. So the county has services, maybe the other free clinic, well, we funnel them in as a clearinghouse.
Right.
Because a patient that comes from overseas barely speaks English, they're intimidated by the system. But if we say, oh, you do qualify for this, clinic in the inner city because you live here, and we've done our job. No cost, just a simple, clearinghouse, if you will. And then you have those that maybe don't qualify for A, B, and C under Obamacare. Eventually, maybe it'll all be there. That's where we want to just supplement.
I just want to add one thing because I got to run. Is what we've done at our current clinic is we've actually recruited patient navigators. That's what we call them. And that's exactly what they do. We actually got a grant for that from the feds. So basically our job is, we right now got 2 patient navigators who are going to be directing patients, filling in the gaps, and helping patients choose exchanges when they come out on October 31st. So that's huge. I mean, these navigators cost us, like $15-20 an hour, and we're getting paid, a little bit more than that. So it covers our cost, and that's exactly. The other model I've seen is a group in Camden who started a Medicaid ACO, where he's actually getting guaranteed payment from the state
He's actually
to care for the very complex patients.